Hello. Thanks for viewing this module. This topic that we will discuss today is on cardiac ultrasound with a particular focus on the parasternal windows. So we'll highlight the different windows throughout these modules that we use to insonate the heart and the benefits of each one of those windows. But today we'll particularly focus in the most part on the parasternal windows and how these windows can give us an appropriate view of the ventricles to allow us to assess systolic function and overall contractility. So as I just mentioned, there are several windows or placements of where you put the ultrasound probe on the patient's chest to view or insonate the heart. These are broken down to four traditional windows: the suprasternal, right parasternal, left parasternal, apical, and subcostal or subxiphoid. Of those four traditional windows, really the left parasternal, apical, and subxiphoid or subcostal views are the ones, or windows are the ones that we primarily use for the majority of adult cardiac ultrasound. There are comprehensive TTE examinations that include over 20 different views of the heart. But for this course purposes, we will be focusing on the three windows I just mentioned: left parasternal, apical, and subcostal, with a total of 6 views from those 3 windows. So for this section, we'll talk about, again, the parasternal window and how the parasternal window will provide 2 particular views of interest of allowing us to insonate the heart. These are the parasternal long axis view, which, as the name says, will allow us to have a long axis cross-section of the left ventricle, and the parasternal short axis view, which will allow us to get a cross-section of the left ventricle. So how do we obtain these views? Well, for the long axis view, which is traditionally the first view when it comes to a cardiac examination that I perform, because it really allows us to get an orientation of where the heart sits in the patient's chest. As we all know, the patient's, if my hand here is the patient's ventricle, it's very often the case that they can be sitting in a much more horizontal or vertical position in a given patient's chest. And so the parasternal long axis view allows us to sort of get an assessment of how the ventricle is laying out in that patient's chest. So how do we obtain this? We place the ultrasound probe 3rd to 4th rib space right next to the sternum, and that's the very key component of this, is that we want to make sure that your footprint of the ultrasound probe is really adjacent to that left parasternal location. Again, 3rd or 4th rib space. The indicator will be aiming at the patient's right shoulder, or roughly the 10 o'clock position, and that will allow us to get the following cross-section of the heart. Particular structures of interest that we will see here: we get a nice long axis of the left ventricle. We'll be able to identify the mitral valve, the left ventricular outflow tract, the aortic valve, and the left atrium. Because of the fact that our ultrasound probe is literally right on top of these structures, we have the shortest depth to our cardiac structures of interest. And because we have the shortest depth from the placement of the ultrasound probe to the cardiac structures, this view will allow us to have the highest potential image quality, assuming we have no artifact generation from the lungs or other pathologies. Basically, the ventricle is the closest to the ultrasound probe in this view, and therefore it should provide the most detailed 2D image. One of the key things I would like to highlight here is that because it provides a great 2D image, it allows us to get measurements of various cardiac structures with perhaps the most precision. One of those measurements is the left atrial diameter or size. And very important to realize, although not completely for the discussion today, is the concept that the left atrium has often been regarded as the hemoglobin A1C of the heart, meaning that if the left atrium is dilated, that will most likely signify that the patient has some sort of heart failure prognosis. And what I mean by that is that all different mechanisms of heart failure will produce an elevated left ventricular and diastolic pressure. Whether you have severe valvular abnormalities, whether you have severe systolic dysfunction, or severe diastolic dysfunction, all of those will potentially produce an elevated left ventricular and diastolic pressure, which will get relayed and cause a dilation of the left atrium. So therefore, a good marker for overall cardiac status is the diameter of the left atrium, meaning that if the left atrium is not dilated, one can often appreciate that the heart should be without severe abnormalities. However, if the left atrium is dilated, that is definitely a warning sign that you can expect potential cardiac abnormalities to exist. And you can see the measurements here as reference. So we talked a little bit about this, but again, the parasternal long axis view allows one to see many of the cardiac structures with the greatest resolution because the ultrasound probe is so close to those given structures. It allows us to get that orientation of the heart to see exactly where the apex is lying relative to the atria. Good, again, because it's so close, because we have the most highest quality imaging. It's a good view to be able to get measurements of chamber sizes. Additionally, you can actually make a long axis cross-section of the RV, although slightly more advanced when it comes to the point-of-care ultrasound setting, by simply rotating your probe counterclockwise and decreasing the angle to allow a more superficial cross-section of that heart. Very important to highlight that, as we talked about in the physics section, this is not the view that you want to use to quantify valvular function. And that's simply because of the fact that flow is now moving perpendicular to the ultrasound plane. And by going perpendicular to the ultrasound plane, you're not able to quantify the direction or magnitude of velocity change simply because the ultrasound plane is not in the path of the flow pattern. We'll talk about the other view and windows that we use to actually quantify valvular function. But again, the parasternal views are not ideal because of the fact that we are perpendicular rather than parallel to flow. Again, left atrial size is a key component of evaluating when it comes to getting the long axis view. We already mentioned about the fact that it has been designated as often regarded as the hemoglobin A1C of the heart because of the fact that it gives that indication of an elevated left atrial pressure. Additionally, the RV, although we'll go back to that 2D picture in a second, often should be very small and not taking a large part of the picture. Because it is so close to the ultrasound probe, this is an ideal view to be able to get size estimation of the RV as well. So again, here just to highlight structures that we're looking at here, RV right on top, following with the left ventricle and a long axis cross section here. We see the left atrium, we see the mitral valve, we see the aortic valve here. We see the reference ranges for size measurements. Very important as we talk further about how we use these to get references of overall preload and filling status by getting an estimation of what the size of the ventricle is in diastole versus systole, as well as when it comes to the left atrium, we mentioned about its key component of determining left atrial pressures. So very important to, where do you do these measurements? The measurements are often performed at the mid-papillary level where you are excluding the papillary muscles. And that's an important concept to how you train your eye. What we're really trying to do when it comes to assessing ventricular function and size, you really want to try to evaluate the measurement or change in the ventricular size, which is what this animation is trying to show, in diastole versus systole. And again, this red line here shows you where we would potentially get the diameter of the left atrium. So with this concept of looking at the change in the diameter at the mid-papillary level in the parasternal long axis view from diastole to systole, that concept is what's called fractional shortening. So fractional shortening is measuring the diameter in this location of when the heart is maximally dilated and diastole versus maximally contracted during end systole. And that difference over the diameter and diastole is the fractional shortening calculation. Normal should be greater than 30%, meaning that, again, visually you should see more than a 30% change in the diameter in this pattern. Anecdotally, you can roughly estimate the patient's EF by simply doing 2 times this value that you calculated. Here again, this diagram shows the utility of potentially using M mode to get more precise measurements, and how you would assess that via the following pattern change and calculation. Now we'll go into the parasternal short axis view. And the key highlight about the parasternal short axis view is that it allows us to get a representation of the heart that's very familiar to many acute care providers. And that is that cross-section, that short axis cross-section of the LV. It is the ideal view to be able to get an assessment of regional wall motion abnormalities, because you're getting a cross-section of all the different walls of that left ventricle at that exact image. Key things to remember is that you can actually adjust what anatomy you're intubating by adjusting the angle at which your probe sits on the patient's chest. Meaning that if you have the angle of the ultrasound probe aiming closer to the sternum, you'll get a cross-section of the aortic valve and maybe the basal segment of the left ventricle and mitral valve. And by moving the ultrasound plane away from the sternum, you'll change the cross-section and go further down the left ventricle into the mid-papillary and apical levels. So important to realize that, again, we've said this several times before, understanding the ultrasound plane, emitting from the ultrasound probe, is key to determine troubleshooting of the 2D image and to anticipate what the 2D image will look like, again, with the understanding of where your ultrasound plane is intubating the body. The other key thing to highlight about the left parasternal short axis view is that it is most often the view that's frequently used to determine the mechanism of shock. And we'll talk about that a little bit further on the subsequent slides. So again, how do we obtain this view? Well, probe placement is the exact same of third to fourth rib space, with the footprint sitting right next to the left parasternal border. But now our indicator has rotated 90 degrees from that right shoulder, now gone to the left shoulder, or the 2 o'clock position. And again, now we've simply gone from a long axis cross-section of the LV to a short axis cross-section. This cartoon is trying to highlight the point that we just talked about, that by adjusting the angle of your ultrasound probe, if you aim it more towards the chest, you'll get short axis view of the aortic valve and the basal segment of the LV, and further changing that angle further and further away from the sternum will allow you to cut the left ventricle at different cross sections, from the basal level with the mitral valve to the mid-papillary level as far down to the apex. Another strategy, besides just adjusting your angle, is sliding the ultrasound probe away from the sternum to be able to do the same mechanism of adjusting different cross sections. This video clip here is showing that transition of going from the left parasternal in a high, closer to the sternum section of the aortic valve, and then scanning down to the mid-papillary level. And so we'll just play this again. Here's the aortic valve, and we're scanning it by adjusting our probe away from the sternum to the mid-papillary level. And again, we mentioned this earlier, that the key component of one of the key benefits of this view is that the left parasternal short axis view allows us to get a cross-section of all coronary distributions in that exact image. So it's very good to detect regional wall motion abnormalities. And this cartoon here, simply, I refer you to the handout, will tell you the different coronary perfusions to the different segments of the heart. And the key point of this again is that the left parasternal short axis view is the ideal view to detect regional wall motion abnormalities in these areas of different coronary perfusion. Additionally, how do we determine the idea of contractility from this view? Well, now we're, instead of looking at the diameter change, we're actually going to calculate the area. So we'll trace out the area of the left ventricle in diastole and compare that to the area in systole. And that concept is called fractional area change. Again, remember that all measurements are done at the mid-papillary level. The other key thing to highlight is that because now the concept of fractional area change is factoring all borders of the ventricle, or all walls of the ventricle, you actually can potentially get a more precise estimate of overall contractility compared to the fractional shortening calculation. And again, that's simply because of the fact that the fractional shortening calculation looks at two walls versus the fractional area change actually looks at all the different walls of the left ventricle at the mid-papillary level. So here is a picture and the calculation. Again, you're comparing the area in diastole minus the area in systole over the area of diastole again and getting that percentage. Normally it should be more than 50%. And again, this is often the view used to visually estimate overall systolic function of the left ventricle. And so again, I'd like to encourage the idea of, like, when it comes to the evaluation of point of care, we're simply looking to see if the heart has more of a normal contractile pattern like this shown above versus a picture like this where the heart in fact is almost completely non-contractile. And to highlight this further, you're able to help differentiate the mechanism of shock in your patient by obtaining this parasternal short axis view. And so let's talk about this as it comes to the change in that area of the heart from diastole to systole. So in cardiogenic shock, as you would imagine, there is very minimal change from diastole to systole, and therefore ultrasound is very useful to detect that minimal change from diastole to systole. Similarly, the assessment of hypovolemia is determined by assessing the expansion of the ventricle in diastole. So getting a true sense of the diameter or area change as it takes on more blood during the diastolic phase, and appreciating that increase in size is a good marker of determining volume status, overall preload status in your patient. In particular, it helps differentiate the possibility of hypovolemic shock, meaning that if your heart never expands much in diastole on point of care ultrasound, that is a warning sign and concern for the patient being hypovolemic. Finally, vasogenic shock is simply representing a low afterload state. So this patient population should have a similar motion pattern from the hypovolemic shock scenario. However, the key difference between hypovolemic shock and vasogenic shock is that the diameter should expand appropriately in end diastole in the purely vasogenic shock phenomenon, meaning that your heart expands appropriately during diastole and takes on more blood, and then is able to have a very vigorous systolic phase simply because of the fact of the low afterload state. However, in hypovolemic shock, remember that in diastole, the heart is not able to expand simply because it does not have volume on board. So again, assessing the expansion or the left ventricular end diastolic diameter is key to be able to determine the mechanism of shock in your patient. Here's a picture of a normal parasternal short axis view. And again, the idea of what we're trying to do is evaluate the change from diastole to systole. Compare that previous video clip to this one here, where we see that during diastole and systole, the red versus beige, there's minimal change. And so this is a individual who does not have appropriate expansion in diastole, secondary to being hypovolemic. All right, so for this section, we're going to review the parasternal windows, and from that window, we're going to identify two views: the parasternal long axis view and the parasternal short axis view. To obtain those views, you're going to identify roughly the third or fourth earth space of your patient. Initially, I always try to go with the parasternal long axis view to get an idea of the orientation of the heart. So the starting point for that would be third or fourth earth space, have the indicator aiming at the patient's right shoulder. The key thing about this is that you want the footprint of your ultrasound probe to be resting just as you come off the sternum. Often people start off fairly lateral from the sternum, and I would encourage you to first initially place the probe very much proximal to the sternum. So here we're now placing our probe on that sternum, third or fourth rib space, sliding to the point where I'm in between rib space, trying to avoid that lung parenchyma to evaluate the cardiac structures that we're trying to see here. And so here's an ideal parasternal long axis view. Again, our indicator aiming at the right shoulder. We see the structures that you can identify here as we talked about in the PowerPoint. Good long axis view of the left ventricle. Our ultrasound plane again is in this fashion, getting a long axis cross section of the left ventricle. We can adjust our tilt to be able to bring the left ventricle more in the middle of the screen, and that's what I'll do to achieve the middle of the left ventricle to be in the middle of my screen before I rotate my probe to the short axis plane. So what that basically entails is rotating 90 degrees or rotating the probe from the right shoulder to the left shoulder. And so here, indicator now, which is at the right shoulder, rotating that to the left shoulder to get a true short axis cross section of the LV. And then here we see the papillary muscles. Remember, it's important, how do you identify to have a good cross section of the LV to look for size and fractional area change? You want to make sure that your papillary muscles are equal in size. That will help you identify that you have a true cross section of the left ventricle. And here you can identify this is a patient with normal contractility. And just for comparison, we can load up a patient with pathology. Here is somebody with severe systolic dysfunction. You can see very poor contractility. Again, the indicator aiming at that left shoulder for a short axis fashion. You can see the left ventricle is much more large than it was previously on the normal simulator image. So that's the parasternal window, and again we've identified the parasternal long axis and parasternal short axis views.